When we consider psychosis spectrum symptoms in adolescence, we can refer to previous population-based studies of children and adolescents, which show that these experiences are actually quite frequent. A study in 2012 that looked at all existing studies performing a meta-analysis showed that 17% of children and 7.5% of adolescents endorse some psychosis like symptoms. These symptoms may be transient or they may be longer lasting. Now, the evolution into persistent or worsening symptoms of psychosis may be influenced and moderated by several different variables, such as the severity of symptoms, whether they are mild, then they're typically more transient, or whether they build up over time. The type of symptom, for example, auditory phenomena and suspiciousness, maybe more ominous signs for progression to psychosis, at least in the population that we see. If there's comorbid depression, anxiety, and substance use, those also are risk factors for later development of full-blown psychosis, as well as traumatic or stressful experiences, those being during childhood, as well as more proximal to the onset of these symptoms. People who face socioeconomic disadvantages and neglect or deprivation, in particular during the early childhood phase, are at increased risk. There may be some race differences, as well as we know that if there's a genetic family history of psychotic disorders, in particular in first-degree relatives, then there's a higher likelihood that the psychosis-like symptoms will progress and worsen. This slide shows us that there are some subtle behavioral differences that already start in early childhood that may confer or predict later risk of onset of schizophrenia. But these differences are mainly based on retrospective studies. However, if adequately identified, interventions during this period of time could facilitate improved trajectory and change the onset of psychosis or outcome. There are these differences in development may be related to developmental risk factors as well as genetic predisposition. They include cognitive, motor, and social impairment during early childhood. For example, it has been shown that young children ages 4 to 6 who later develop schizophrenia or a psychotic disorder already show differences in terms of their motor development, social interaction, and cognitive functioning. Later during childhood and early adolescence, what is commonly seen is the emergence of anxiety and depressive symptoms that can be fairly nonspecific. Then during later adolescence and more proximal to the onset of psychosis, young people may develop social withdrawal and subjective cognitive changes. For example, a significant proportion of young people who later develop psychosis are diagnosed with attention deficit disorder during this period of time and may also be treated. Following this stage, there may be the onset of prodromal symptoms, and these symptoms can be brief and fleeting, or they may last for months, if not years, and are characterized by subtle symptoms of psychosis, be that hearing whispering of noises or voices when there's no one around. That may be misinterpretation of common events, that a person may feel that these events relate to them when in fact they're neutral, a person may develop beliefs that other people don't share about society or the world around them, and may experience disorganized thinking without any of these symptoms reaching psychosis threshold, but then eventually leading to full psychosis presentation. Psychosis symptoms during first episode psychosis fall into three main clusters. Those of positive symptoms, which are characterized by hallucinations or abnormal sensory experiences of including stimuli that are not in the environment, such as hearing voices, seeing things, having feelings on the body or within the body, as well as strange smells, or delusions, which are erratic beliefs that people around the person do not share. Common delusions are paranoid or suspicious delusions that involve safety. Other delusions may include delusions of grandeur, being especially important, religious delusions that are not shared by the person's religious environment, somatic delusions such as having an illness that is not yet diagnosed, and more subtle delusions such as misinterpretation of common stimuli, feeling that certain events have particular importance to the person. Negative symptoms are the absence of normal functioning, and these include lack of emotional expression or affective flattening involving speech, gestures, or facial expressions, anhedonia, or the lack of enjoyment in common activities, avolition, or difficulty with motivation, as well as a lack of output of speech or substance of speech. And the third category or cluster are disorganized symptoms. So this may be subtle disorganization of speech patterns that can actually range from being illogical to being fully incoherent to the observer, as well as disorganized or erratic behavior. When we talk about the clinical high-risk state or the prodromal stage to psychosis, we are referring to the presence of symptoms that are considered subthreshold psychosis symptoms. So they do not reach the severity that we see in a person who experiences full-blown psychosis. The best understood and accepted state of clinical high risk is really that involving what are attenuated positive symptoms. And here a person can have delusions or hallucinations, but not to the point that they reach a psychosis threshold, which typically means that the person is not fully convinced of these experiences, and these experiences do not significantly affect the person's behavior and actions. Other risk states exist, such as attenuated negative symptoms as a prodrome to psychosis, and attenuated disorganized symptoms, again, very similar to what is seen in psychosis, but to a lesser severity. The features that distinguish subthreshold from threshold psychosis symptoms I briefly mentioned before, and these consist of the degree of conviction and meaning that a person has about these experiences, typically about hallucinations or delusions, the degree that they are distressed or bothered by these experiences, and how these experiences affect their functioning and their activity in everyday life, as well as the frequency and duration, which may range from having an experience rarely, every now and then, possibly once a week, to having daily experiences, to the point of that a person feels preoccupied by ongoing hallucinations, which can happen in psychosis. I will now present a case of threshold and another case of subthreshold psychosis. The first case is Troy, who is a 22-year-old white male. Troy indicated that he experiences a tugging in his brain, which happens at least a little bit every day and lasts until I can get it out. It is good if I can channel it right, like if I'm working out, it could fuel you. It can eat you alive. He had difficulty describing what the tugging sensation felt like, but reported, you know, when magnets repel, it feels like that. That same kind of thing where they are slipping around. Convert that into my head. He reported full conviction and stated that it bothers him when it forces him to behave inappropriately, such as an incident when his mother was being nice to him, but then I'll feel the tugging and I'll get overwhelmed. It is such a struggle to speak. It creates a tension and I needed to get out, and I screamed at my mom and had to run upstairs. He rated his impairment for this sensation as a 6 out of 10 because I had to quit my job because of it. So here we have several identifiers that go along with Troy experiencing psychosis threshold symptoms, such as him experiencing a tugging in his brain. So this could be a casual occurrence. For him, it occurs at least a little bit every day. But then he describes that it influences him. And he describes it in a way that shows some disorganized thinking. When he says, it is good if I can channel it right, like if I'm working out, it could fuel you. So it can eat you alive. So somewhat disorganized, illogical explanation. He states he has full conviction, and it actually forces him to behave in certain ways, including when he described becoming overwhelmed when his mother was talking to him nicely, at which point he exhibited an inappropriate kind of response, an inappropriate behavior, somewhat aggressive towards his mother, which did not relate at all to the question asked or to his mother's behavior. Also, he had to quit his job because of it. So even though that he describes this tugging in his brain to be not happening all the time, it does affect him significantly in his interactions with other people. Now, here we have Jennifer, who is a 16-year-old woman, reporting that she hears her name being called about 3 times a month. She says this experience began in the past year and can happen anywhere. She said she's unsure why it is happening, saying she doesn't know what to make of it. She denied that it bothers her, but that it is weird. When she hears her name being called, she often turns to look or asks people if they heard it too, which they did not. She denied hearing any other words or sounds. So what Jennifer is experiencing are rare auditory phenomena of her name being called, which happens a few times a month at seemingly unpredictable intervals. And she's somewhat puzzled by it, but denies that these experiences bother her, though she finds them kind of strange, and at times has asked people whether they have heard her name being called as well, seemingly having some reassurance when they tell her that this did not happen. So we have psychosis type experiences of auditory phenomena, but they do not reach the severity, frequency, or the impact that we see with hallucinations that cross the psychosis threshold. What makes this clinical high risk also is that these experiences started, or in other cases, as may be, could have worsened over the past year and not longer standing and stable.